All right. Hey guys, so I wanted to give you guys a week 3 quiz review. So this is going to cover chapters 16, 18, 19, and 20. So we looked at basically alterations in cardiac function, cardiovascular disease like coronary heart disease, heart attack, heart failure. In chapter 20 would have looked at different types of shock, right? Okay, so... Right, so and even before I start and begin, you have to understand the normal physiology of, blood pressure and blood pressure regulation and things like that, to then also be able to understand, well, if there's some alterations or if there's some challenges or difficulties or patho portion of these topics, then it's easier for you to understand the pathophysiology if you already understand the physiology, right? Understanding cardiac output, right? Understanding that it's heart rate times, stroke volume and things like that. So we have to understand that first to be able to then understand like the problems and the challenges. One of the challenges we talked about with cardiac dysfunction was hypertension, right? So hypertension again is going to be the most common primary diagnosis in the United States. And so there's going to be 2 types of hypertension, okay? So we have primary hypertension, which is also called essential hypertension. This is an idiopathic disease, meaning there's not a clearly identifiable cause of this disease, right? But again, this is the most common, right? This is going to be the most common type, okay? So we can put most common type. Right? So if you have a question, well, what is the most common type of hypertension? Primary hypertension, right? And then we have secondary hypertension, and this is going to be specifically attributed to a specific identifiable condition or pathology, okay? So understand that difference between primary and secondary. Now, if a person has, hypertension, which is just simply high blood pressure, what are some things that we want to do? Right? Of course, weight loss, right? Some lifestyle alterations. Weight loss is going to have the greatest impact on lowering your blood pressure, right? Exercise for sure, enacting a DASH diet or incorporating that DASH diet high in fruits and vegetables, low in fatty foods, right? Low in cholesterol and things like that. Alcohol moderation, decreasing the amount of alcohol consumption, and decreasing sodium intake, right? And I even put right there, what would you do for a person, right? You have a patient and they present to you with hypertension, right? What is one of the lifestyle modifications you can prescribe? Really restricting that sodium intake, right? Because it's going to retain that water, which is going to retain their blood volume, increasing their blood volume, thus increasing their blood pressure. That's hypertension, right? So we want to be able to restrict that sodium intake or decrease it at least, right? Now we know that hypertension alone increases the risk of atherosclerosis, right? So again, think of these in the cases of patients. If a patient presents with you, whether they're middle-aged patient or elderly patient, right? They present to you and their lab levels are, they have high LDLs, right? Which is going to be high in cholesterol, low in protein, right? If they present to you like that, right, it's probably going to be, atherosclerosis, right? They're going to have that high risk of atherosclerosis. And we know, alone that it's the hypertension that increases the risk for the atherosclerosis. And then you have the low density lipoproteins on top of that, then that's going to definitely increase your risk, right, of coronary artery disease, okay? So we have to be able to make those connections, okay? Now, when we look at a hypertensive crisis, and I want to talk about that too. So another question you'll see, hypertensive crisis, that's going to be characterized by a diastolic pressure being greater than 120, right? And in addition, so if you see a diastolic number, right, reading that's higher than 120 millimeters of mercury, and they're going to have symptoms of end organ damage, such as, for example, retinopathy or ischemic stroke, right? This is going to be classified as a hypertensive crisis, right? So when you make your note cards, for example, right, hypertensive crisis, right? on the same side or in the back or whatever, right? You're right. You know, greater than 120 millimeters of mercury, right, for diastolic, and end stage or end organ damage, and include examples such as retinopathy and ischemic stroke. Okay. When we look at low blood pressure, which is hypotension, right? Hypotension. Well, number one, what will hypotension result in? Right. So remember these symptoms of hypotension, of low blood pressure, right? Dizziness, that's number one. Blurred vision, number two. Confusion, number three. And the possibility of syncope, like passing out, right? Number four, right? So when you do your notes, right, you know, on one side of the note card, right, this is just an example, if you want to use this example or not, right, you put low blood pressure or hypotension, right? That's one side. And on the other side of your note card, you put, you know, symptoms, right? So the symptomology of this is going to be dizziness, blurred vision, right? Confusion, obviously still on the note card, right? Syncope, right? So that's one of the study tools that you can use, right? Just a simple note card method that could help you. So again, hypotension is low blood pressure that can result in like dizziness, blurred vision, confusion. You know, possibly the person will pass out, for example. Now, when we look at orthostatic or postural hypotension, that's going to be resulting from an extreme response to a change from a supine to an upright position, right? So if you pick your head up too fast, right, and you feel like dizzy or lightheadedness, right? Might have some blurred vision too, right? Possibly you could faint too, right, with the syncope. So that's an example of orthostatic hypertension, when you have an extreme drop in your hypertension. Extreme drop in your blood pressure. Again, moving from a supine to an upright position. Now, when we're looking at this orthostatic hypotension, right, it can be associated with cardiovascular disease. And so, you know, given some of the risk factors, right, orthostatic hypotension is a risk factor for what? Stroke, cognitive impairment, and even death. Let's do it again, right? Orthostatic hypotension, right? And on the other side, you can put what it is, right? Drop in blood pressure, moving from a supine to an upright position, right? And you can finish it off, right? And then what is it associated with, right? It's a risk factor for, right, stroke, cognitive impairment, put the other eye right there, and death, right? So you got to remember that, okay, about orthostatic hypotension. And so, sorry. Nope. Let me go back right there, sorry. I want to change the color for a second. Now let me talk about when there is a drop in blood pressure. So you have to understand what your body's going to do when you have a drop in blood pressure. Now we talk about the RAS system all the time, right? So the RAS system is going to stand for the renin-angiotensin-aldosterone system, okay? This system is going to get turned on because your kidneys is going to recognize that there is a drop in blood pressure. When there is a drop in blood pressure, there's a couple of different ways, right, that will be able to release renin. Now, for example, when we're looking at that juxtaglomerular apparatus of the kidneys, specifically at that glomerulus apparatus, right, within the like that nephron. So you have these granular cells. The granular cells are going to be these renin-releasing cells, and they are baroreceptors. And so they measure pressure, right? So these cells that measure pressure will release renin. When they measure or they recognize that there is a drop in blood pressure, these renin-releasing cells will release or secrete renin. Renin will go into the blood, right? and it will convert that already circulating angiotensinogen, which is inactive. It will basically activate it. It'll cleave it, right? Converting angiotensinogen into angiotensin 1. Angiotensin 1 travels around in the blood, right? Comes across the lungs, right? So this is in the lungs, this enzyme. In the lungs, you have this enzyme called ACE, angiotensin converting enzyme, that will convert angiotensin 1 into angiotensin 2. Now, angiotensin 2, like we talk about, is going to do everything that it can to raise your blood pressure, right? Because initially there was a drop in blood pressure. Angiotensin 2 goes to your peripheral blood vessels, constrict them. If you constrict them, you're going to raise your blood pressure. That's doing the opposite of that initial stimulus. Boom. Angiotensin 2 is going to go to the adrenal glands, the adrenal cortex, and tell it to release aldosterone. Aldosterone then goes to the kidneys, tell the kidneys to reabsorb sodium. Water's going to follow. You increase your blood volume. You increase your blood pressure. Another way of how we're increasing blood pressure. Angiotensin 2 goes to the hypothalamus, right? Tells the hypothalamus to release vasopressin, antidiuretic hormone. That goes to the kidneys so you can retain water. You retain water, increasing your blood volume, you're increasing your blood pressure. Again, doing the opposite of that initial stimulus, okay? So a person that has high blood pressure, right, will give them certain drugs, such as like an ACE inhibitor, right? So an ACE inhibitor, right, will inhibit that. It will inhibit the ACE, right? It will inhibit the angiotensin converting enzyme. So essentially what it's going to do, and remember this, right, it's going to block the conversion of angiotensin 1 into angiotensin 2. That's what the ACE inhibitor is going to do. So as a result, you're not constricting your blood vessel. As a result, your blood pressure is not going up. As a result, you're not releasing aldosterone. You're not reabsorbing sodium. You're not reabsorbing water, right? So as a result, your blood pressure is not increasing. So that's one of the mechanisms of those type of drugs, like an ACE inhibitor. Just simply blocking that conversion right there, right? Okay. Okay, moving on. Now, coronary heart disease. And so what is the main cause? Let me ask you that. What is the main cause of coronary heart disease? Well, the main cause of coronary heart disease is going to be atherosclerosis of those coronary arteries, right? And so some risk factors for coronary heart disease through coronary atherosclerosis is, of course, age, family history, hyperlipidemia, meaning abnormal lipid levels or too high of lipid levels, obviously cigarette smoking, hypertension alone can contribute to atherosclerosis, diabetes, and obesity can also contribute to it, okay? And in most cases, it's ischemia. It's going to be a result of impaired blood flow through these coronary arteries, which can lead to a myocardial infarction or a heart attack, okay? Now, when we look at, I'm going to jump over here for a second at the acute coronary syndrome. And so this is basically a range of these diseases that ranges from, angina, unstable angina, to myocardial infarction, to cardiac arrest. And so you got to remember that, right? This ACS, or acute coronary syndrome, how will it present? It can present as unstable angina, a myocardial infarction, and or sudden cardiac arrest. Okay, so you got to remember that. Okay, so put acute coronary syndrome other side, and I want you to make these too, right? Can present as unstable angina, myocardial infarction, sudden cardiac arrest, right? Get in the habit of making these like note cards, and they'll definitely help you, especially when the select all apply, right? Those select all applies, they tend to get us. So we want to be able to be prepared for it, okay? Now, when I'm looking at acute coronary syndrome, right, yeah, it can range from unstable angina to a myocardial infarction to sudden cardiac arrest, meaning your heart just stops, right? Now, when I'm looking at angina, right, so chest pain, right? So, and we'll get to how are we able to identify, was that chest pain actually just angina, or was that chest pain a heart attack, right? So if it was just angina pectoris or just chest pain, right? That's going to be caused by intermittent or temporary myocardial ischemia. So intermittent blockages in blood flow, right? Or reduced blood flow that's going to be caused by like a stenotic atherosclerotic vessel, okay? And so what we notice though with this angina is you have pain, right? Especially with physical exertion, right? But here's the thing, that pain tends to go away with what? Rest. That's how we know it was just angina pectoris, right? Versus, oh, was this a heart attack? Because in order for it to be a heart attack, then for us to diagnose it, we're going to diagnose a heart attack based on a couple of different things. And you see this ST elevation, right? And some serum biomarkers. Let me go to the next slide. So this is how we diagnose a myocardial infarction or a heart attack, right? Number one, signs and symptoms, sure, right? It's going to be characterized by severe, crushing, excruciating chest pain that can radiate to your arm, shoulder, jaw, and back, right? Typically, that pain is going to be accompanied by nausea, vomiting, diaphoresis, like sweating, and of course, shortness of breath, right? Now, it contrasts from angina because this infarction pain generally lasts more than 15 minutes and is not relieved by rest, right? And we know that, heart attacks can be asymptomatic and they can elude detection, right? So we can have silent heart attacks. But again, you'll have these signs and symptoms. It's possible that you'll have these signs and symptoms. You'll also have elevated levels in specific biomarker proteins. So if you have elevated levels of troponin, for example, or lactate dehydrogenase, things like that, so we'll take the blood and we'll be able to look and say, oh, okay, this person has damage to their myocardium because these proteins leaked out and now they're in the blood. So increased serum levels, right? Increased blood levels of these certain proteins. That's one way. Another way of how we were able to diagnose this person actually had a heart attack. Now, what is the most or the best way, right? Some textbooks will say, well, what is the best way, or how can we clearly identify if a person actually had a heart attack or not? And it really would be these ECG changes, right? Specifically the ST elevation, okay? Specifically the ST elevation, okay? So this right here is going to be the most reliable indicator of a myocardial infarction, okay? So definitely write that out, okay? Now, when we look at some other diseases, of the nocardium, valvular diseases, pericardial diseases, we have rheumatic heart disease, right? Rheumatic heart disease is uncommon, but it is a serious consequence, though, of rheumatic fever. And so what is rheumatic fever? It's going to be an inflammatory disease that's really going to be caused by these group A beta hemolytic streptococci species, okay? So you got to remember that, all right? That rheumatic heart disease is going to be due to those beta hemolytic streptococci species. We also have infective endocarditis, where you just have an inflammation of the endocardium, and typically it's like invasion and colonization of like microorganisms, especially on that like mitral valve or the bicuspid valve, and they could damage that valve, right, and result in inflammation, really. Now, when we look at pericardial infusion, that's just simply a accumulation of fluid in the pericardial sac, right? And if this fluid, accumulation is large or it occurs suddenly, it can be a life-threatening condition, right? And this is where we have that cardiac tamponade, right, that will ensue. And so, tamponade will refer to the external compression of the heart chambers, such as that the filling is impaired. So if there's too much pressure on the heart, remember the function of the heart is to fill up with blood and then pump to eject the blood out. But if there's too much pressure on it, it won't be able to fill up, right? So as a result, you'll have a decrease in cardiac output, which will lead to a decrease in blood pressure. So you have to remember these three classic symptoms of cardiac tamponade: hypotension, distended neck veins, and muffled heart sounds. All right? One more time, let me do it. Okay. Cardiac tamponade. Other side. All right? three symptoms, right? Hypotension, distended neck vein, and then muffled heart sounds. Okay, you get the idea, right? So write it out, okay? Definitely will help. When we get some congenital heart diseases, there's a couple, but I only really will focus on just one right here. And that's going to be the patent ductus arteriosus. And so I just really want, this is quick, like a quick review too. So notice that there is a normal channel between the aorta and the pulmonary artery. And this is that ductus arteriosus. And so whenever you're asked about a ductus arteriosus, remember that from like anatomy. This is just that normal channel, right? That the fetus have between the aorta and the pulmonary artery. And it will typically close up after they're born. It's even with this portion right here, right? It'll become that fossa valley, okay? Now, ideally, these like openings, they should close up, but sometimes they don't. Now, heart failure. Heart failure is this clinical syndrome resulting from a primary condition which inhibits the heart's ability to maintain sufficient cardiac output. So when we're looking at heart failure, right, the common denominator in all forms of heart failure is reduced cardiac output. The heart is not able to maintain a sufficient cardiac output to optimally meet the metabolic demands of your organs and your tissues. All right. So whenever you think of heart failure, your heart is failing. And so it's failing to maintain adequate cardiac output. As a result, your tissues, your organs, are not going to get adequate nutrient oxygen, right? So again, remember that common denominator in all forms of heart failure, reduced cardiac output. Now we have, left-sided heart failure. Now, what is the most common type of heart failure? Left-sided. So left-sided heart failure is going to be the most common type of heart failure. We have a forward effect and a backward effect of heart failure, okay? Now, what is the backward effect of heart failure, right? So you have to think about when we're looking at the heart, right? And I don't have that much space, right? I'll draw it right here. So you have the right atrium, left atrium. Oh, Lord. Right atrium, right ventricle, left atrium, left ventricle. All right, now I'll make it a little bit bigger too, because we know that left ventricle is a little bit bigger, right? Blood always will, or deoxygenated blood will enter the right atrium, right, to go to the right ventricle. Then it goes to the lungs, right? From the lungs, it comes back to the left atrium, to the left ventricle, and then it goes to the body, right? But I should also say, from the body, right, the body's going to dump deoxygenated blood into the right atrium, again, going through the tricuspid valve to get to the right ventricle. Then it's going to leave via the pulmonary artery to go to the lungs to get oxygenated. It comes back to the heart, oxygenated, to the left atrium, through the bicuspid mitral valve to get to the left ventricle. From the left ventricle, it leaves oxygenated to oxygenate the tissues of the body. So that's just your basic blood flow throughout the heart, right? Now, if you have left-sided heart failure, now I'll do this, right? So if this part is diseased, it's failing, right? It's not able to pump, right? So that is going to back up. It's going to back up where? It's going to back up into the lungs if you have left-sided heart failure. So that's why that backward effect of left-sided heart failure is going to be pulmonary congestion. So you're going to have congestion in the pulmonary system, congestion in the lungs, okay? And so as we can see here, that left-sided heart failure is going to lead to fluid accumulation. Where? In the pulmonary system, in the lungs, okay? And so this is essentially the ineffective pumping of the left ventricle, resulting in that pulmonary congestion, okay? So we got to remember that. And I'll talk about right-sided heart failure in a second, but because I got this image right here, if the lungs have so much fluid in them, right, now the right side of the heart has to pump a little bit harder to push that fluid into the lungs, right? And if the right side has to work so much harder, then that's going to lead to right ventricular hypertrophy, because then it has to work harder to push that fluid into the lungs. And that's what we're going to call right ventricular hypertrophy. And that right ventricle gets bigger because it has to do a little bit more work. And that condition is going to be called cor pulmonale. And I'll mention that on the next slide as well. Now, I want you to remember the backward effect, which is going to be pulmonary congestion. The forward effect is because, remember, if this left ventricle is failing, right? Yeah, you're going to have fluid filled up in the lungs, but it's not able to pump blood to the body. So as a result, you're going to have diminished delivery of oxygen, diminished delivery of nutrients to the peripheral tissues and organs, because the body is not going to get oxygen and nutrients like it normally should. Okay, so remember also some backward effects too, right? Such as that paroxysmal nocturnal dyspnea, right? And this is where you have dyspnea that's going to occur at nighttime, right? Okay, so this dyspnea, this difficulty breathing, this shortness of breath, right, is going to be caused at nighttime. So remember that about paroxysmal nocturnal dyspnea. Okay, whereas orthopnea is going to be difficulty breathing, shortness of breath while you're just lying down. Okay. Now I want to talk about. Nope, not that. Let me do that. Right-sided heart failure. Wow, sorry. I wish it was over. So we know that the forward effect is, again, diminished delivery of oxygen and nutrients. Now, right-sided heart failure is when now the right side of the heart is failing. And it's typically going to be preceded by left-sided heart failure. So left-sided heart failure happens first, right? And then that will lead to right-sided heart failure. Now, the backward effect of right-sided heart failure is going to be systemic venous congestion, right? So the right side heart failure is going to be systemic congestion, okay? Meaning you're going to have, right, ascites, right? So all that fluid filling up in your abdomen. You're going to have, edema, right? So look at that edema in these legs right here. So you got to remember that about the backward effect, okay, of right-sided heart failure. Now, what are some things that could also lead to right-sided heart failure? Pulmonary stenosis, right? Right-sided heart failure. On the other side, I'm going to put that can result in right-sided heart failure. Pulmonary stenosis, right? Obviously, left-sided heart failure can result in this as well, okay? And like I mentioned in the previous slide, with left-sided heart failure, it's congestion in the pulmonary system, right? And so as a result, the right side has to work a little bit harder, and the right side is going to start growing. It's going to start remodeling itself. And so you're going to have right ventricular hypertrophy. And that right ventricular hypertrophy, which is secondary or a result from that pulmonary stenosis, or that pulmonary congestion rather, it's going to lead to a condition called cor pulmonale, okay? Cor pulmonale, right? Left-sided heart failure, which will lead to pulmonary congestion, which will lead to right ventricular hypertrophy. That's called cor pulmonale, right? So use the arrows like how I just used as well, right? That would also help as well when you're trying to look at these different diseases. Try to make it in an order, right? Now, cardiac dysrhythmias, we mentioned this just briefly. So cardiac dysrhythmias is where we have the abnormality in pulse generation. Okay, so what is these dysrhythmias? What are they indicative of? This is what I want you to understand, right? These dysrhythmias are indicative of an underlying pathophysiological disorder, and you know they can impair normal cardiac output as a result. If you have the misgeneration or the off generation of the electrical impulse that's going throughout the heart. Okay. Last but not least, we talk about shock, right? So let me talk about cardiogenic shock. You'll see this for sure. Okay. Cardiogenic shock, right? Basically, whenever you think of cardiogenic shock, let's just think of it as a reduced cardiac output. Simple. Cardiogenic shock is where you have reduced cardiac output, right? Meaning you have dysfunction of your ventricles, so you are not able to pump out blood effectively. So that's why you have a reduced cardiac output. So you got to remember that condition of cardiogenic shock, right? And as you can see it right here, decreased cardiac output. Okay. When we have hypovolemic shock, that's going to result from simply inadequate circulating blood volume, right? Meaning you don't have that much blood volume. As a result, if you have decreased blood volume, you have decreased blood pressure, right? So you have a drop in blood pressure with hypovolemic shock. And even with cardiogenic shock, you have a decrease in cardiac output, which ultimately means you will have a decrease in blood pressure as well, okay? Obstructive shock, right, develops when the heart is prevented from pumping, right, by mechanical obstruction, right? So something is blocking the flow of blood, essentially, right? And so what are some of the causes of obstructive shock, right? Obstructive shock. So some of the causes, right, will include pulmonary embolism, right? Cardiac tamponade that we just looked at, right? Too much pressure on the heart and it's obstructing it from flowing correctly, as well as a tension pneumothorax, right? So remember, these are causes of obstructive shock, okay? Now, when we're looking at distributive shock, remember the different types of distributive shock. We have anaphylactic shock, neurogenic shock, and septic shock. Whenever we're looking at distributive shock, so for example, conditions of anaphylactic shock and neurogenic shock, what will that be caused by? Well, it's going to be caused by peripheral pooling of blood. Peripheral pooling of blood, okay, which would then lead to hypotension. Again, another drop in blood pressure. Okay, gotta remember that about distributive types of shock, and remember the different types of distributive shock and what this leads to. These conditions will lead to peripheral pooling of blood. Okay, and so when we look at anaphylactic shock, this is going to result from an excessive mast cell degranulation, right? And remember, what is that mast cell going to degranulate? What is it going to release? Histamine. Okay, which will result in a pooling of blood, which will result in a dramatic decrease in your blood pressure, right? Hypotension. Okay, most causes of these anaphylactic shock cases will be caused by a sensitive person being sensitized to these antibiotics. Now, what are the clinical manifestations of anaphylactic shock? Right, so in your notes, right? Anaphylactic shock. Clinical manifestations is hypotension, right? Urticardia, these hives, itching, angioedema. Right, so remember these select all, right, as well as wheezing too. Let's add that in there as well, as well as wheezing too. These are clinical manifestations of anaphylactic shock. Now, neurogenic shock is going to be really any injury to the brain or spinal cord, and that can result in a loss of sympathetic activation, right? Loss of sympathetic activation to your arterial smooth muscle, which they keep it constricted. So as a result, if you're not keeping it constricted, you're going to dilate it, which would lead to a drop in blood pressure. Okay. And then last but not least, septic shock, right? Now, septic shock is going to result from a severe systemic inflammatory response to like an infection, for example, like a bacterial infection or a fungal infection, for example. Now, well, what are some of the symptoms, right, from septic shock? Well, let's write this out too, right? It's not on the slide, but let's write it out because you want to remember it, right? So some symptoms of septic shock is going to be fever, for sure, right? Drop in blood pressure, right? Or we can say hypotension, right? You'll also see conditions or symptoms with, or it will present clinically with lactic acidosis as well, right? So remember these three clinical manifestations of septic shock, okay? And just remember in general the different types of shock. Again, with all of them, you're going to have a drop in blood pressure, okay? So make sure you pay attention to the highlight. Make sure you pay attention to the stars. Make sure you do your note cards, like how I just did these, right? You probably have a lot of note cards, right? Which is fine. Alrighty. Happy studies.